Welcome. The American Association of Neurological Surgeons is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The AANS designates this live activity for maximum of 1 AMA PRA Category 1 credit. As a provider accredited by the Accreditation Council for Continuing Medical Education, the AANS must ensure balance, independence, objectivity, and scientific rigor in all its sponsored educational activities. In accordance with the ACCME standards for integrity and independence in accredited education, the AANS is required to disclose to the activity audience the relevant financial relationships of the planners, faculty, and any other individual in a position to control content of this activity. Those who have disclosed a relationship with ineligible companies are listed on the current slide. All disclosed financial relationships have been mitigated in accordance with ACCME standards. Planners, faculty, and any other individuals in control of content not listed have indicated that they have no relevant financial relationships or conflicts of interest to disclose for this activity. Credit claiming will be available in our learning management system, NeuroU. Claiming instructions are on the screen and will be shared again at the conclusion of this webinar. By the end of the week, participants will receive an email notification of enrollment to claim credit. For any issues or questions regarding claiming credit, please contact education@aans.org. Now to get us started, I would like to introduce Dr. Hajipanias.
Thank you, Tim. Thank you, everyone, for joining today. We're so excited to have Dr. Mark Bilski be part of our next Spinal Oncology Tumor webinar series here. The webinars that we've developed through the AANS CNS Joint Tumor section are so important to our educational mission. I'd like to remind our viewers that these webinars are recorded. They're on our website, the tumorsection.org website, and they will be there for you to see if you can't join us today. This is a CME accredited webinar. And I would like to also thank Jim Bailey, Nam Tram, for moderating the session, and also Chris Newman, Pascal Zinn, for organizing our Spinal Oncology webinar series. Dr. Mark Bilski is a figure in spinal oncology and really has taught us so many things, and I'd like to hand it over to our moderators to formally introduce him. Thank you so much for joining us today.
Thanks, Kostas. Hey, everybody. Good afternoon. I'm Jim Bailey, an assistant professor of neurosurgery at the University of Pittsburgh, and I specialize in spinal oncology. I thank you all for joining us today for this session, the CNS Tumor webinar series on spinal oncology. It's my honor to welcome our guest, Dr. Mark Bilski, someone who honestly needs no introduction for anyone who regularly treats spinal metastatic disease. But for those who may not be familiar, Dr. Mark Bilski is a renowned neurosurgeon and one of the leading experts in the treatment of spinal tumors. He's currently the William E. Snare Chair of Neurosurgery at Cornell and the Memorial Sloan Kettering Cancer Center, where he's the chief of their multidisciplinary spine tumor service. He's made numerous and significant contributions to this field of spinal oncology, particularly when it comes to metastatic disease. And he'll be sharing his insights and work on this topic with us today. We're honored to have him with us, so please join me in welcoming Dr. Bilski.
Tim, thank you so much for the introduction, and Kostas and Nam and Maria. This is really an honor and a privilege for me, and I hope to share what we've sort of done over the last 30 years to try to develop this field of medicine, which was largely, when we started, wasn't ignored, but there wasn't really much to hang your hat on. And fortunately, I've been in a cancer center where they let me just study this problem for really the last 25 years as an integrated program. And we're going to try to share what we've learned and how much this has moved and how it continues to grow and evolve, and hopefully get people interested in studying this maybe in their careers. I certainly didn't start out in spinal oncology. I really started on brain and cranial-based malignancies. But this has taken over in such a major way, and there were so many advancements that we'll try to share in the next maybe 35 or 40 minutes, and then hopefully we'll have time for questions. 20% of cancer patients will develop spinal metastases over the course of their illness, and we've definitely seen an increased number over the past 10 to 15 years. Partly it's an ascertainment issue that MR and FDG-PRET have improved detection, but also the systemic treatments have improved survival. But the biologics and checkpoint inhibitors seem to be much more effective for visceral than for bone disease. So we think we're going to see a continued uptick in the number of tumors that we're responsible for. And despite this improved survival, the treatment remains palliative. We want to improve and maintain neurologic function, achieve local tumor control, mechanical stability, pain relief, improve quality of life, and then an early return to systemic therapy. And if we get this kind of outcome, this patient doing this 100-mile paddle on this whitewater river, having undergone separation surgery for an L3 mechanical radiculopathy, we've clearly done our job in palliation versus this patient who has both failed fixation and a radiation recall burn requiring extension of hardware and a free flap reconstruction. Everything we've done in the past 30 years is to mitigate this kind of outcome. There have really been three periods, at least since I've been around in spine tumors, that have evolved over the last 50 years. Initially, up through the 1980s, we had two treatment options, laminectomy with instrumentation and conventional external beam radiation. Laminectomy with instrumentation was obviously a terrible operation, created iatrogenic instability, deformity, progressive pain, and often neurologic decline. Compared to conventional external beam radiation, often given as 30 gray in 10 fractions. A paper as early as 1978 by Gilbert Kim and my great mentor, Jerry Posner, showed that solid tumors were what they called unfavorable responders, or what we now call radioresistant. And despite these poor responses, conventional radiation was as effective as decompressive laminectomy. And when I started, it was standard of care. By the mid-1990s, we had the development of segmental instrumentation, transarterial embolization for hypervascular tumors, and then the Patchell study 2005 showed that surgery was better than conventional external beam radiation for solid tumor malignancies. And with that, we began to see this proliferation of incredibly aggressive approaches, often that were not well tolerated in this population, including en bloc spondylectomy. And during this period, the decision-making algorithms were largely surgically based, such as the Tomita and Takahashi scores. By 2010, we had the development, evolution, integration of truly transformative technology in the form of stereotactic radiosurgery. It's defined as high-dose perfection conformal photon beam delivery, often given as 16 to 24 gray single fraction or 24 to 30 gray in 3 fractions. And compared to conventional external beam radiation, the responses are both histology independent and ablative, and that fundamentally changed our indications for and type of surgery that we do. For those patients that were undergoing en bloc resection based on the Tomita and Takahashi scores, we now often do definitive radiosurgery. For those patients with high-grade cord compression with or without myelopathy, where we were doing intralesional gross total, we can now do this really simple separation surgery followed by radiosurgery, which we now call hybrid therapy. And we can use minimally invasive stabilization techniques such as kyphoid vertebroplasty with an assurity that we'll get control of tumor with radiosurgery. With the integration of radiosurgery, the decision-making was mandated to become multimodality. At Memorial, we use the GNOMES decision framework, where radiosurgery is fundamentally the most important for tumor control, and surgery is largely an adjuvant to radiosurgery for decompression and stabilization. In the GNOMES framework, there are 4 sentinel decision points: neurologic, oncologic, mechanical stability, and systemic disease to decide best treatment. It's an algorithm at any point in time, but we largely leave it as a decision framework so that we can integrate evidence-based medicine and new technologies as they become available. This is the kind of patient that GNOMES is really effective for. This patient population is remarkably complicated. And this is a typical case example, right? 76-year-old who's got pathogenic thyroid, BRAF positive. 2020 underwent a thyroidectomy, was put on solumetinib with RAI, and 2 years later he developed back pain. It initially was biologic back pain, that night or morning pain that gets better over the course of the day and sort of denotes just that tumor is there. This is the pain that often responds to steroids, and then it changed. It became severe axial load and recumbency pain reflective of fracture. It was neurologically normal. 5 out of 5 upper lung extremities and sensory was intact. And you can see this really high-grade cord compression at T5 with a plain and burst fracture and bilateral posterior element disease. And then he's got medical problems, right? Comes in with hypothyroidism, he's got cardiac stents, he's a chronic COPD, and then on systemic workup, his PET scan shows an inordinate amount of bone disease and pulmonary nodules. And the question is, how do you take all of this information and try to consolidate it so that you can make very effective, consistent, and expedited treatment plans? And so we take this patient, he's he's got high-grade cord compression, not myelopathic. The pathogenic thyroid cancer is resistant to conventional external beam radiation, which is the only treatment you can use in the setting of high-grade cord compression, at least traditionally. He's mechanically unstable, and his systemic disease shows that he's got probably a 1-year survival, and his medical clearance puts him at moderate risk. So this patient is a very good candidate for something like hybrid therapies, separation surgery, followed by radiosurgery. And we'll talk about the evidence that supports this kind of decision as we go through this talk. In the NOMS framework, the neurologic and oncologic considerations are made in combination. From a neurologic perspective, we're very concerned about myelopathy and functional radiculopathy, but much of the decision-making is based on the degree of epidural spinal cord compression. There's a scoring system that's been validated where 0 is bone only, when A, B, and C are different degrees of epidural impingement without spinal cord compression. 2 is spinal cord compression, but CSF is seen. 3 is spinal cord compression, no CSF seen. And for decision-making purposes, the 2s and 3s are considered to be high-grade cord compression. From an oncologic perspective, what we're really talking about is how we achieve local tumor control. Local tumor control, at least to us, is completely predicated on the radiation response, and radiosensitivity has been completely redefined as we've transitioned from conventional external beam radiation to radiosurgery. Now, there are still radiosensitive tumors to conventional radiation, that 30 gray in 10 fractions, such as the hematologic malignancies, lymphoma, myeloma, and then the hormone-driven solid tumor malignancies, such as breast and prostate. The remainder of the solid tumors are largely radio-resistant to conventional radiation, with median durable responses of 3 months and 2-year local control rates of only 30%. Here's a patient with multiple myeloma with 3-level high-grade cord compression, T10 to 12, comes in as an ASIA C. Put this patient on high-dose steroids, gave conventional external beam radiation, and you can see the 10-day follow-up film. The tumor completely apoptosed, decompressing the spinal cord and recovering the patient to normal neurologic function. Here's a patient with prostate cancer with high-grade cord compression who is not myelopathic. And in the setting of high-grade cord compression with breast or prostate in the absence of myelopathy, we're very comfortable taking those patients to conventional external beam radiation. The problem in the myelopathic patients, it takes a very long time to actually see a decompression, a response of the epidural tumor, and you're not going to get a fast enough response to get recovery of function. So in high-grade cord compression, breast or prostate, we often will use conventional external beam radiation. If they're myelopathic, we take them to surgery. So there's still a role for conventional external beam radiation in the treatment of metastatic disease, but for patients with radio-resistant tumors, those solid tumor malignancies, short of breast and prostate, with minimal or no spinal cord compression, where we have a definitive target, we go straight to radiosurgery. Here's our initial series of a little over 800 tumors, mostly with radio-resistant tumor histologies, where we had a definitive target for radiation with ESCC scores 0 to 1C. Contours were according to Radiosurgery Consortium guidelines. There were 2 dose cohorts. The median dose of the planning target volume, the low dose cohort, was 16.4 gray single fraction versus the high dose cohort, 22.4 gray. The only factor significant in the insulocal failure was the dose of radiation, but even in the low dose cohort at 16.4 gray single fraction, we only had a 5% failure rate at a year, but it increased to 20% at 4 years. In the high dose cohort, we had less than 1% failure rate at a year, increasing to 2.1% at 4 years. We overcome radio resistance with high dose perfraction radiation, and these responses become both histology and volume independent. Now, much of the past 10 to 15 years has been trying to define dose constraints for organs at risk. And the most important is obviously to the spinal cord. And at a cord D max of 14 gray single fraction, we have less than a 1% chance of creating myelitis. But it's that dose constraint on the spinal cord that prevents us from treating high-grade cord compression, at least with single fraction radiation. Because either we're going to overdose at the margin of the cord and create radiation myelitis, or we're going to underdose at the margin of the cord and risk epidural progression where we need the greatest tumor control. Now, it turns out that we improve the therapeutic window. We're going to give up a little bit of tumor control, but have much less toxicity when we go to hypofractionated radiation, often defined as 24 to 30 gray in 3 fractions. So as opposed to single fraction, using hypofractionated radiation may get us very good tumor control, but spare spinal cord tolerance. Here was our original series of 31 tumors where we treated to a median dose of 27 gray and 3 for grade 2 compression, and the 2-year local recurrence was only 22%. So in those patients who are older, sicker, who may not tolerate surgery, it may be a very good bailout just to do hypofractionated radiation. Here's our more recent series of a little over 2,700 tumors treated with 3 fractionation schemes, 24 gray in 1 versus hypofractionated 30 gray, 27 to 30 gray in 3 fractions. And 24 gray single fraction was still better than 30 gray in 3. But what we could do with a hypofractionated radiation was again treat high-grade cord compression. And if we compared patients with hypofractionated radiation comparing 0 to 1 Cs versus high-grade cord compression 2-3 with no decompression of the spinal cord, our 2-year local failures were identical with no toxicity from this treatment. So our 2-year local failure was 14% ESCC 0 to 1 C versus 17% treating high-grade cord compression. The next question is there any benefit to surgery in this population? And it turns out that we had about 600 patients who were treated for high-grade cord compression with hypofractionated radiation, of which half underwent separation surgery versus half getting SBRT only. Overall, there was no difference in outcome. So 8.2% failure rate in the separation surgery, the hybrid therapy group, versus 17% in the SBRT only. But when you look at radio-resistant tumors, those solid tumor malignancies, the differences get bigger. But remember, in this very older, sick population, we're only talking about a 20% failure rate for radio-resistant tumors with SBRT only. And so more and more, we're looking at high-grade cord compression in the absence of myelopathy for potentially radiation only, especially if they have a hard time tolerating surgery. They're just not surgical candidates. We do have a good bailout with radiation. It will take a long time for this to permeate the radiation literature and convince radiation oncologists that this is safe and effective. And at least for now, for patients with radio-resistant tumors with high-grade cord compression with or without myelopathy, most centers are going to surgery followed by radiosurgery. This is largely still predicated on the Patchell study published Lancet 2005. It's a prospective randomized trial, as you all know, of solid tumors with myelopathy comparing surgery and conventional external beam to conventional external beam alone. And in every outcome variable, surgery was better than radiation. And based on that and a number of other studies, the Spinal Oncology Study Group made a strong recommendation that patients with high-grade spinal cord compression due to solid tumor malignancy undergo surgical decompression and stabilization followed by radiation therapy. The question became what kind of surgery and what kind of radiation. With the integration of radiosurgery as a postoperative adjuvant, the surgical goals of spinal cord decompression for neurologic salvage and using screw rod systems to provide mechanical stability remain the same. What changed, right, is the oncology. How we achieve local tumor control is completely predicated, at least in our eyes, on the radiation response. So when we use conventional external beam radiation as a postoperative adjuvant, it often made sense to do maximally cytoreductive surgery, either gross total resection or en bloc. With radiosurgery as a postoperative adjuvant, maybe the only goal, right, has to be to reconstitute the thecal sac to create a better target for radiation, and that became known as separation surgery. Here, an 86-year-old female with pathologic thyroid Asia C, you can see this really high-grade cord compression, 3-level vertebral body disease. And I would submit to you there is no way to get this patient through a 3-level front-back surgery. In separation surgery, it's all done from a posterior approach. Traditionally, we instrumented 2 levels above and below the index level. We take a high-speed 3-millimeter matchstick. We drill off the lamina, superior and inferior facet joint, and pedicle flush the vertebral body. We strip the tumor from normal dural planes, and then we resect the PLL to affect the margin on the anterior dura. And from a posterior-only approach, you can get a very effective circumferential decompression of the epidural disease. The goal of separation surgery is not necessarily to take out all the tumor, but simply to reconstitute the thecal sac to create a better target for radiation. Why do we like separation surgery in metastatic disease? They're very short operating times, usually 2.5 hours. We can do emergency operations for epidural tumor in the middle of the night without the need for an approach surgeon or without the incumbent morbidity associated with anterior transcavitary approaches. And we can do these large volume, multi-compartmental tumors, such as the one on the right, where our only real obligation is to decompress the tumor within that blue circle and leave the remainder of that tumor for radiosurgery. And ultimately, we do a better and safer epidural decompression because we're always working from normal dural planes. In terms of approach morbidity, one of the most difficult areas to reach is C1-2. And the best approach for that, traditionally, especially in the primary tumors, is a transmandibular osteotomy. Here we use it for a low-grade chondrosarcoma. We split the jaw. In a primary tumor, it's probably justified, but in the metastatic population, they will not tolerate. They have to be pegged and trached for a minimum of 2 to 3 weeks after the surgery, and that's a lot of recovery in somebody trying to get back to systemic therapy early. In this case, we actually put a cage anteriorly. It was sort of in vogue to try to get bone graft, although, again, all of the load at C1-2 comes through the posterior element, so this was probably unnecessary. And at 8 years, we were looking through the mouth at this cage, had to do a pharyngeal reconstruction. And in point of fact, we got excellent bone graft in the back, again, where all of that load is. So this was probably unnecessary. But the incumbent morbidity of simply doing a transmandibular osteotomy in this population is really prohibitive. Here's an example of a 33-year-old female in contradistinction who had multiple fibroids resected. She was 3 months pregnant, tripped on an airplane jetway, was acutely quadriplegic from the C1-2 tumor, causing high-grade cord compression. We did an emergency separation surgery where we reconstituted the thecal sac, but left all this residual tumor behind with an occipitocervical fixation. By the grace of goodness, she got neurologic recovery at 2 months. It ended up being a low-grade uterine leiomyosarcoma. We gave her adjuvant IGRT, photon-based, conventionally fractionated radiation, 66 gray and 33 fractions. Today, we would use a hypofractionated regimen, 30 gray and 3 fractions, using either IGRT, photon-based IGRT, or proton beam radiation. The baby was born 4 months after the injury. Here's the tumor that we left behind after separation surgery that got her neurologic recovery. Here's a 17-year follow-up film with no evidence of residual recurrent tumor. It's not about the amount of tumor you take out. It's about the response to radiation that gives you durable control. Here's a 54-year-old female with a high cervical myelopathy and clumsy hand syndrome with needle biopsy. We knew this was chordoma and not a candidate for en bloc resection due to high-grade cord compression with bilateral vertebral artery and this large paraspinal mass. The intent was to do a separation surgery to make a target for radiation, then potentially go back and resect the residual tumor. We did a separation surgery. You can see we reconstituted the thecal sac, but we left all this tumor behind. We gave 24 gray single fraction radiation. We never went back to resect that tumor. Here's a 7-year follow-up film with no evidence of residual recurrent tumor. Again, it's about the response to radiation that defines a long-term durable control and not necessarily how much tumor you take out. And I'll show you some of the chordoma data in a minute. Improvements to separation surgery. Traditionally, we went long segment fixation, minimum 2 levels above and below the index level, in part to distribute load in osteoporotic bone, and in part to prevent failure from adjacent segment progression. And in that construct, we only had a 2.8% failure rate using that long segment fixation. More recently, we switched to short segment cement augmented fenestrated pedicle screws, single level above and below the index level that are cemented in, that overcomes that osteoporosis and potential for adjacent segment failure. And in that construct, at least in our initial 44 patients, our fixation failure rate that required a reinstrumentation was 2%. More recently, we've looked at 400 patients with this construct, and it's up to about 4.1%, but it's a very effective construct in this patient population. And now we're going to minimally invasive techniques for decompression on very selected patients. I think oftentimes it's very difficult to control bleeding through a tube. So if you have a massively hypervascular tumor, there may not be a benefit, but we're certainly starting to integrate this to try to, again, reduce the morbidity from this surgery. In terms of choice of implants, there's lots of things that are really critical in this. One is durability, 2 is imaging for recurrence, and 3 is how it impacts your radiation delivery. Cement augmentation obviously used a lot for vertebral kyphoplasty, and now to cement our screws in. It has excellent durability. There's no imaging artifact. There's no photon-based SBRT issues, so you can give SBRT with no penalty. We actually do not have data on protons and carbon ions as far as its effects, so we don't actually know how that impacts radiation delivery. In posterior hardware particularly, people are really interested and have been using titanium hardware for decades, and now there's carbon fiber PEEK, where there are a number of instrumentation companies that are starting to develop this, and it really is the first instrumentation that was developed specifically for tumor application, although I'm sure over time it will have much wider application. Titanium hardware actually, as I showed you, has excellent durability. Imaging for occurrence is often very good, depending on how you put your construct in, and sometimes we have to go to focal MR imaging, fine cut MR, to actually see behind the hardware, but we have very effective strategies for that. In terms of radiation, it's very hard to do an MRCT simulation for radiation, so very often we'll go to myelo-CT. There's no photon-based SBRT delivery issues, so we can very effectively account for that hardware in our dose delivery with photons, but there are massive issues with protons and carbon ions. In terms of peak carbon fiber, again, excellent durability, very similar to titanium hardware. There's a definite benefit in imaging for recurrence compared to titanium, but it's not as significant as one would think most of the time. Oftentimes, again, we may have to go to focal MR with titanium, but we have very good imaging. In terms of radiation, though, you can very effectively do an MRCT simulation. There's no photon-based SBRT issues as with titanium, but there's a huge benefit in protons and carbon ions, and that's really where this great benefit is coming in. As we get more and more proton centers, and now even carbon ions coming to the U.S., these peak instrumentation constructs will become more and more important. The one thing I will cancel on your titanium hardware is, even though we're pretty good at seeing for recurrence and we don't have issues with delivery of photon-based SBRT, you have to be really careful with the construct that you put in. This was a patient at L1-2 compression fractures and ended up with this very long construct, which I think in degenerative and trauma may be really acceptable. But the two things that really are prohibitive for us in terms of being able to effectively either look for recurrence or deliver radiation is they did a dual rod construct, but they put the dual rod over the canal so that we couldn't instrument. We can't see the canal at all. And then you have to be super careful with these titanium expandable because they have that big titanium ring, and that puts a huge amount of artifact across the canal that hurts our ability to give photon-based radiation, but also see recurrence. So be really mindful if you're putting a titanium hardware, and you may have to alter your strategy so that, again, we can image the canal and then effectively deliver radiation. In terms of separation surgery, in terms of outcomes, 75% of our non-ambulatory patients regained the ability to ambulate, and overall 90% were ambulatory. In terms of patient-reported outcomes, patients did significantly well in terms of pain right now and general activity. In terms of tumor control, there's only one series that looked longitudinally using very aggressive surgery followed by conventional external beam radiation. It was Clay-Camp-Sammy, published in 1998. And if you did really aggressive surgery followed by conventional external beam radiation, the local control was only 30% of the year. And one of the biggest predictors of recurrence was radioresistant tumor histology. Here's our initial series of separation surgery followed by radiosurgery, what we now call hybrid therapy, in 186 patients. Most were operated for high-grade cord compression with radioresistant tumor histologies, and 50% had failed prior radiation. There were 3-dose strategies: high-dose single fraction, 24 gray, high-dose hypofractionated radiation, 8 to 10 gray times 3, and then low-dose hypofractionated 6 gray times 5. The 1-year cumulative of recurrence was only 16%, but if we gave a high enough dose single or high-dose hypofractionated radiation, we had less than 10% recurrence at a year. Again, there's no association with radioresistant tumor histologies. We overcome radioresistance with high-dose perfraction radiation. Here's a more recent series of hybrid therapy looking at histology-specific progression-free survival using the separation surgery followed by a median dose of 9 gray times 3 for renal cell carcinoma, 2-year progression-free survival, 92%, non-small cell lung cancer, 95%. Colon cancer did a little less well, 2-year progression-free survival, 87%. We looked at mutation status, and if a patient had an EGFR mutation was treatment naive, we had a 50% improved overall and progression-free survival, and for colon cancer, APC was a negative prognostic mutation. Now, this is the nightmare for people, especially in community hospitals or people where there's a large emergency room. And that's the patient who comes in with myelopathy from a tumor of unknown histology. So they have no history of cancer and they come into your emergency room. And the question is what do you do? Do you biopsy and wait, or do you take them for surgery? And my argument is going to be take them to surgery. For solid tumors, we've made the argument that you should do hybrid therapy, and I think that's pretty well established. For hematologic malignancies, if you could definitively get a diagnosis in a timely fashion, you potentially could treat with radiation alone. If you got a diagnosis of myeloma or lymphoma, the problem is it's very, very hard to get a definitive diagnosis in a timely fashion. So you need a biopsy and you get a small blue cell tumor and you make the assumption that it's lymphoma, but it could be Ewing's or it could be a neuroblastic tumor, something that's not going to respond dramatically, and you're not going to get this immediate decompression. And so you're justified, if you cannot establish a diagnosis definitively in timely fashion, take them to surgery and get them out of trouble. And the last one is it's going to be a primary malignancy, such as chordoma. And the argument is made over and over that you need to en bloc for wider marginal margins to cure chordoma. It turns out that chordoma is remarkably radiosensitive if you give a big enough dose. So this was a 53-year-old who presented ASIA-C with no preceding history of cancer. So you see this incredibly high-grade cord compression 2 levels with vertebral body disease. And this ended up being a chordoma. They were taken at an outside hospital in Connecticut for simple separation surgery with standard reconstruction in the metastatic population. And with that decompression and reconstruction, they got neurologic recovery, and it ended up being chordoma. Again, with high-grade cord compression, there's no way that you can en bloc for cure. We didn't have enough room to give 24 gray single fraction, which is our preference for chordoma, and so we took them back for a redecompression to reconstitute the thecal sac. And we didn't like this construct for durability in somebody who was going to live a long time, and so we took them back and re-instrumented with cement augmented screws, a dual rod construct that's outside the canal. We did a vascularized rib graft, posterior lateral, and then autologous iliac crest graft on the contralateral side. We gave 24 gray single fraction. Here's the 4-year follow-up film with no evidence of residual recurrent tumor on standard MR DCE imaging. How effective is this strategy in chordoma? We looked at 35 patients in the mobile spine. If we had a definitive target for radiation with no high-grade cord compression, we simply took them to definitive radiation. But if they had high-grade cord compression with or without myelopathy, initially we did curettage gross total resection. And then as we got more comfortable with our tumor control, we simply did separation surgery followed by radiosurgery. If we gave 24 gray single fraction, regardless of what other treatment they got, either as definitive radiation in the mobile spine or intralesional gross total separation surgery, our 5-year local recurrence-free survival is 90%, very similar to what we're seeing in the metastatic population. Is there evidence from other centers that this is true? Again, we think the chordoma is remarkably radiosensitive as you get to a BED greater than 70 gray. And a 24 gray single fraction, our BED, is about 150 gray. This is MD Anderson using the radiation, a 24 gray single fraction as definitive treatment for mostly chordoma and then some chondrosarcomas. Their numbers exactly the same as ours, 5-year local control rates of 90% with no surgery. Can you use carbon ions and protons? And the answer in the postoperative setting, the answer we think is yes, very effectively. But again, you may need to use carbon instrumentation. This is a super interesting series from Italy of 33 patients. There were 2 cohorts. At initial therapy, they had patients who underwent en bloc, of which 12 were for wider marginal resection. And then they had a separate cohort at first recurrence that underwent curettage intralesional resection, followed by carbon ions and protons. And there's no difference in local tumor control, whether you do an en bloc wider marginal or curettage intralesional with carbon ions and protons. And so you'll start to see these paradigms for chordoma begin to shift. But in that setting of high-grade cord compression, do not biopsy, get a chordoma diagnosis, and think that you're going to en bloc for cure. Get them out of trouble, and then get them to effective radiation. So we talked about the neurologic and oncologic indications. The separate indication for treatment is mechanical instability. Why? Because no amount of radiation will stabilize an unstable spine. The SINS criteria is developed to define instability in the neoplastic setting. There are 6 criteria for instability, which are all weighted by their contribution. 0 to 6 is considered stable, 7 to 12 potentially unstable, and greater than 13 unstable. For those patients with painful burst and compression fractures in the thoracic and lumbar spine, which often fall into that SINS category of potentially unstable, they're very good candidates for kypho and vertebroplasty. And there is class 1 evidence from the CAFE study, which was done mostly at Moffitt, so thank you all, that showed that kyphoplasty was better than best medical management at a month, durable out to a year. It turns out that if you have a burst or compression fracture with extension into the posterior elements, you can't do standalone kyphoplasty. They need a posterior tension band, and we now do that with percutaneous screws that are cement augmented with kyphoplasty at the index level. And in our initial series of these 46 patients, again, we took patients from severe pain to minimal or no pain post-treatment. And then there are patients like this, as you all know, where we have significant fracture subluxation here at C1, C2, where we don't have percutaneous procedures for these, and this patient still needs to go for an open occipitocervical fixation for fracture subluxation instability at C1, 2. We're trying more and more to tailor our treatment to the patient's needs, and we see a lot of C1 lateral mass fractures, and they get severe neck pain for a couple of days and then it gets better. But what they're left with is severe occipital neuralgia. And we used to take these patients for OC fusion with a C1-2 decompression to decompress the nerve root. And then we realized that their only real problem is occipital neuralgia. And we now do C2 nerve root ablations, and 80% of those patients will avoid surgery. And then the big problem in cancer treatment oftentimes are these sacral insufficiency fractures. These patients have intractable pelvic pain or are essentially bedbound. We've done a lot of treatments for this. We do bed rest and see if they'll heal, but it often takes 8 to 10 weeks. We've done sacroplasty, which is about 50% effective. We still do instrumented fusion on really complicated patients, but we now do this percutaneously. Max Vainrub has really championed this. But the big and initial therapy for the vast majority of these patients is we do cleneal nerve and dorsal branch L5-3 ablations. And these patients literally are bedbound, and they will get up and walk the next day. We're not fixing the fracture, we're just denervating the sacrum. And the final thing I'll say about instability is we don't really worry about deformity in these patients unless it defines the problem. So we're very happy to fix them in deformity as long as we can get away from their pain. One of the really complicated things we see, and I think if you're in a cancer center like Moffitt, you probably see these patients too, where they get irradiated and they get a fixed chin on chest deformity, really from fibrosis of the sternocleidomastoid, and they are miserable. They're literally fixed looking at the ground. And so deformity in that case really defines the problem. They're not necessarily unstable, they just have a deformity issue. And one of the ways to treat this is you can release the sternocleidomastoid with just Botox into that muscle and get them back to neutral. And unfortunately, this patient required an occipitocervical thoracic fixation, which means we put him in a functional halo. He cannot flex, extend, or rotate, but he has horizontal gaze. He's literally the happiest patient I have, despite the fact that he cannot turn his head. And so you have to adjust what you see in their deformity based on whether it defines their problem, and then fix that problem. And the final issue is you've decided based on NOM that they need surgery or potentially they need radiation therapy, but you have to make sense of it in the context of their disease and what they can tolerate, what makes sense and where they are in terms of their treatment. And so the last assessment is really systemic disease and medical comorbidities. Survival is often used as a determinant to decide whether a patient should go to surgery or radiation. And when we lived through the era of chemotherapy, we knew almost to the day how long somebody would survive. And then we entered this whole new vista of biologics and checkpoint inhibitors. Here, for melanoma, a single checkpoint inhibitor more than tripled survival compared to standard chemotherapy. And there are a million other agents that are effective now against melanoma. And the question was, how do you predict survival with these new agents? It turned out that in our surgical patient, the biologic checkpoint inhibitors made a big difference in survival. So we had a 20% 20% improvement in survival in the era of biologic checkpoint inhibitors. And there are now predictive models of survival that were established in the era of biologic checkpoint inhibitors. So the SORG nomogram and the New England Metastatic Spine Score are very effective at telling you whether a patient is a very short-term survivor, isn't going to make it, 30 days or a month, versus going to live 2 or 3 years. And then you can integrate that into how you see treatment. And then the other side of that is not just survival, but these patients, again, come in with a lot of medical comorbidities, and you have to factor that into what they can tolerate in terms of getting them off into surgery. And the last thing that really affects in the survival category is for oligometastatic disease, often defined as 1 to 5 metastatic tumors. And we've often thought of radiation as only being local therapy, but it turns out that in this setting of oligometastatic disease, there are multiple trials now. The first was Saber Comet, where they compared standard therapy, systemic therapy, to either conventional external beam versus radiosurgery, and considering radiosurgery to be ablative. And in that study, patients who underwent radiosurgery, again, up to 1 to 5 mets, had a significant overall survival advantage. So giving ablative radiation to metastatic disease actually improves their overall systemic disease control. The PISA trial was our trial. It was a randomized bone-only trial, 50% of which were spine tumors, comparing what we think is ablative radiation, 24 gray single fraction to 9 gray times 3. We knew there would be better local control at 24 gray single fraction, but what we didn't expect was that there was a decrease in distant metastases. So a lot of times now, you'll see these sort of small asymptomatic lesions that would never have been irradiated in the past. They weren't symptomatic, they weren't fractured, they weren't at risk for epidural disease, but they're treating them, trying to tap into this effect of better overall survival and decrease in distant metastases. So at least today, as we see the NOMS framework, there's still a role for oh, my arrows aren't working. There we go. Let's see. My arrows aren't working. I apologize. There's still a role for conventional external beam radiation in radiosensitive tumors, regardless of degree of spinal cord compression. For radio-resistant tumors with minimal or no spinal cord compression, we typically go straight to stereotactic radiosurgery. And then for radio-resistant tumors with high-grade cord compression, typically we'll go to separation surgery followed by radiosurgery. But remember, in the patients with high-grade cord compression, with radio-resistant tumors who are not myelopathic, more and more we're going to 3-fraction radiation. If the patient is unstable, it's a separate assessment because no amount of radiation will stabilize an unstable spine, and they're often candidates for kyphovertebroplasty, perc screws, or open surgery, and then everything is predicated on what the patient can tolerate from a systemic disease standpoint. So we go back to that patient, that 78-year-old with papillary thyroid cancer, with multiple treatments, who started out with sort of this biologic back pain that turned mechanical, with high-grade cord compression, plain and burst fracture with bilateral posterior element disease, multiple medical problems with a systemic workup, showing lots of bone disease and pulmonary nodules. Hopefully I've convinced you to sort of separate it out and try to make sense of it in the context of known. So in this case, even though we're myelopathic, we have high-grade cord compression. Papillary thyroid is markedly resistant to conventional external beam radiation. And so traditionally in the NOMS framework, again, we have looked at these patients as surgical based on high-grade cord compression with radio-resistant tumor. But with the new data on hypofractionated radiation, especially in patients who can't tolerate surgery, we're looking more and more at definitive radiation with that 3-fraction radiation. What pushes us over the edge, though, right, is mechanical instability. This patient has a SIN score of 14 based on a burst fracture with bilateral posterior element disease and severe pain related to that fracture. And so even if we could say we take them to radiation based on high-grade cord compression with radio-resistant tumor, they're still grossly unstable, and you have to address that. And then you have to go to the systemic disease assessment. The SORG nomogram says we're going to have a 50% 1-year survival. And we went to medical clearance because he's got COPD and stents, and they put him at a moderate risk. And so it makes sense in this context to take this patient for hybrid therapy, separation surgery, followed by radiosurgery. To us, at least, NOMS is the cornerstone of comprehensive care in the modern management of spine metastases. It allows us to make multidisciplinary clinical decisions that are consistent, timely, and evidence-based, and integrate and develop meaningful technologies. And then what it did for us was it allowed us, because we knew every domain so well, we started to look at these patients, and we could really very effectively develop collaborative clinical and translational research that addressed the holes and the problems that we were seeing in this patient population. There is so much still to discover in this domain, and that's why I hope that this talk in part is useful to teach people, the NOMS framework, although so many people are so well acquainted with it now, but also to get people interested in where we're going. And I think, for the spine people, a lot of it is on the technical side, but the reason we're so interested in the tumor people and the brain people is because you see it as an oncologic problem as opposed to specifically, a spine problem. We still have lots to develop in the surgical domain, definitely more MIS applications. We have a big Da Vinci robot program, but particularly for paraspinal benign tumors. But in the radiation domain, again, there's so much still to look at. And now, because there's a proliferation of proton beam machines, we're trying to figure out where to effectively and meaningfully integrate that. There's lots of papers and translational research still going on. And so, if you're tired of looking at brain tumors and gliomas, we welcome you into our domain to start to solve our problems. And with that, I thank you so much. We probably have time for questions if that's possible at all.
Yeah, I don't know if there are any questions in the chat.
There's one so far. So it's, do you
There
use spinal
are
cord
two
stimulation in
questions.
your practice for pain? And then does it have any interference on radiotherapy? I guess in terms of artifact would be the question.
Yeah, it's a recent evolution. I don't know if Chris is on. Chris actually Newman is our pain guru, and only in the last 5 years have we started to use spinal cord stimulators. Typically, they sit outside the area of interest in terms of radiation. So I think at least the paddles probably don't impact, and the battery I'm sure can be put out outside range. I don't think it actually interferes with radiation, but I don't know that for sure.
Yeah. In terms of in this modern era of targeted therapies and immunotherapy, have you seen more integration with the medical oncologists in using immunotherapy as kind of radiosensitizers to enhance the radio effectiveness of these more resistant tumors?
Oh, thanks so much. That's a great question. So the two really interesting avenues of exploration, there was a paper from Cleveland Clinic looking at I think they demonstrated clinically that VEGF TKIs in combination with radiosurgery act as radiosensitizers for renal cell carcinoma. And there's a really good rationale for that because the radiobiology of hypofractionated radiation, VEGF is an inhibitor of that pathway. And so VEGF inhibitors potentiate the effects of single fraction radiation by affecting, we think, the acid phenylmyelinase pathway, which lends to endothelial apoptosis. And so what they showed in the clinical trial, and there's actually experimental evidence from here, but at 16 gray single fraction in combination with VEGF TKI, so not Bev, but pazopanib, axitinib, is the same response as we saw at 24 gray single fraction. So we see 98% local control 4 years with 24 gray. At 16 gray as a standalone, they got 80% control, and then in combination, they were at 96%. So we think there's a radiobiologic rationale for it, and then we think we see a clinical response. So I think that's a super interesting avenue. We would love to study it. We can't get funded for it. I think it's just, but it's definitely out there. The and then there's this combination. There's definitely a potentiated effect of immunotherapy with SBRT. So our initial study, our anecdotal case, was in renal cell carcinoma of the sacrum. Patient had failed radiation twice, had a 9 cubic centimeter tumor. And because it had been irradiated twice, they weren't willing to irradiate the entire tumor volume, and they were on dual checkpoint inhibitors, IPI and Nivo. And Josh didn't want to give up on this young patient who was just in agony, and so he only irradiated the middle third of that tumor. So 2/3 of the tumor got no radiation dose, again having failed twice radiation, and within 2 months the entire tumor involuted, and so sort of proof in print in a really immunogenic tumor. And they've just completed a trial of Nivo radiation for chordoma at recurrence. And there's apparently a very good signal there too. So you'll start to see, I think, more and more integration of checkpoint inhibitors with radiation, again, trying to potentiate that, antigen sink, and then having these antibodies, T cells act against tumor. And I think there's, it's a work in evolution, but it's definitely super interesting.
Mhm.
And then we like the combination. Superoxide dismutase mimetics are super interesting too. And we had a third generation that we thought was going to be really interesting, got pulled from the market, but there are lots of those, strategies to incorporate, multimodality therapy to potentiate radiation effects.
We have another question on the chat. What would be the most ominous factor during the planning for separation surgery or considering hybrid therapy?
Ominous. I think, that's a great question. I, I think, the whole concept behind separation surgery is to make it effective and fast. I think the bigger issue isn't so much the technical aspects of it. I think, most people can do it extraordinarily well in every center. And patients typically don't pay a big price for it. The bigger question is whether the patient gets benefit from it. So my partner just had a patient who had an AKA on one side. He's got a femur fracture on the other side, T5, high grade cord compression, and um, and not myelopathic yet, right? So the question is, and so what they were really, so they, even if you fix that problem, they weren't going to ambulate, right? They have a femur fracture on one side and AKA on the other side, and so what they were going to treat this for was bowel bladder function. But then you go to the systemic disease, and they have no further systemic options for this patient. And so even though you can fix a problem, right, patient gets no palliative benefit because they're not going to be ambulatory after the surgery unless they fix the femur, which isn't going to happen. Bowel bladder isn't a real issue. You can always, catheterize, and there's no benefit to trying to get a patient out of bed who can't ambulate to try to get to the restroom. And the median survival based on SORG and no systemic options is probably 3 months. So I think the bigger issues and the things we struggle with is we have a solid NOM indication, and the question is, does it make sense in the context of the disease? Those are the struggles that we have more than anything. The technical side of separation surgery, you can virtually get anybody through it. If we have infection issues, or we can always do rotation flaps, those aren't our issues. The bigger issues are the decisions of whether they should go, and that gets super complicated. I think, if you're being really principled in decision making, the nights spent aren't about whether I can get somebody through separation surgery, it's whether they should go at all.
Now, for those surgeons who don't practice in a cancer center, how do you propose to get more buy-in from the radiation oncologist and promote more of that partnership so that they understand the our practice guidelines here with the separation surgery.
Yeah, no, I think that's been the most complicated problem is it's not even getting buy-in from the surgeons, it's getting buy-in from radiation oncology. When we
Mhm.
started, there were probably 5 centers in the US that were doing this in any volume and really studying it. And I think over the last 20 years, they've built a really good roadmap about how to make this technology safe. And then over time, we were really the second application of IMRT, which is as you know, the delivery system for SBRT. but ultimately it really started with prostate and then it went to spine, but now every disease management team, every disease site uses SBRT for their treatment algorithms. And so radiation oncologists across the board, especially as they're a little bit, more junior and have trained on it, are integrating into their practices. So it's not such a foreign concept to them. Brain's had it forever, but the leap from brain to body was really complicated. And so I think now it's a much easier lift for patients to start to integrate, or for radiation oncologists to begin to do this in their own practices. But yeah, we still see it. I mean, there's a lot of resistance because you can still do conventional external beam radiation and it's still, acceptable practice, even though the outcomes aren't nearly as effective. And so it'll take another 10 years, I think, for this to be integrated across the country in a meaningful way, but it'll happen. It'll happen because the generation that is, training now, that's all they're going to know. And it's a senior
Yeah.
generation, that's a harder lift for them to change the way they've done it for years. And I understand that.
Do you find any trouble getting it approved? I have patients where I'll do a separation surgery, we'll send them for radiation, get denied for SBRT, we'll have to treat them with a dose of conventional radiation, say that they failed, and then it's being delayed months and months until afterwards. Do you find that you're pretty much universally getting approval for your radiosurgery?
Yeah, we suffered like you all did, trying to get approval early on. And then, I think there's enough data and prospective data out now that the insurance companies have a hard time denying it. And so it's gotten better for us, but we all went through that. And part of the problem early on for us was we had patients who we thought were great candidates for definitive radiation and couldn't get approval. Now you're waiting a month, 6 weeks, potentially to get that approval. And by that point, they're upstage. So we never decided on surgery based on where they were that day we saw them. We based it on where they were going to be, 6 or 8 weeks from now. And so, yeah, it's complicated, but fortunately there's a Canadian study that showed a benefit to radiosurgery. It was Arjun Segal's Canadian prospective study, and that's what you take to the insurance companies now that may make a difference. We still have problems, and we still have to do, fortunately I don't do them, but I think in the post-op setting, it was never as big a lift as it was in the definitive radiation setting to get that for whatever reason. So at least we didn't have that problem in New York. And then there were places like Michigan where they could ask for it one day and do it the next. I mean, it's just like, it's all over the map. But yeah, it's complicated, but it will get better again as time goes on and more definitive data comes out. But at least we have a prospective study, because the original prospective study was 16 gray versus 8 gray, and it ended up being a negative study. And that was huge because the time points were 3 months, and there may not be a great benefit to radiosurgery at 3 months, but when you get out to 6 months, a year, 2 years, 3 years, and we always say you can pay once or you can pay twice, right? You can do conventional, let them fail, then we go to surgery and do radiosurgery, or you can just give them definitive treatment. So it's gotten better, but yeah, I get it. We can lay out all this stuff, and hopefully, at the end of the day, but it's probably going to take another 5-10 years before this becomes standard in every center and every insurance company accepts it as standard of care.
Okay. And then one other question, kind of piggybacking. You seem to do a lot of 24 gray and single fraction. We happen to be at 3. Your data looked like it was a little better for actually the hypofraction than the single fraction, or is that just a small sample size? Depends on histology.
So in the initial, that's really interesting. In the post-op setting, for whatever reason, and it may be tumoral coverage or whatever, hypofraction does seem to be better. It's not significant, but it's real. In the upfront definitive radiation setting, especially for tumors where we need durable control like chordoma, we're pretty wedded to 24 gray single fraction. And if we can't give that because of volume, et cetera, we're really going to 10 gray times 5, which we didn't talk about. So yeah, in the post-op setting, it's probably a wash, but you probably maybe get better tumoral coverage and tighter dural margins using hypofractionated. And our hypofractionated now, we're pretty wedded to 10 times 3, which was better in our series in 27 in 3.
Well, Dr. Bilski, thank you so much for taking your time to share your knowledge with us. I mean, this is extremely informative, and I'm hoping to, share this webinar with my radiation oncologist and the medical oncologist as well.
Absolute privilege. I hope it's meaningful. I so appreciate your time, and thanks for letting me do this.
Thank you.
Thank you.
Thank you, sir. Yep.
Thank you.